KZN, and we're moving away from the TB HIV theme to Sam. You have to use
that is sort of working. Okay. Afternoon, everybody. So I'm Vanessa Comley. I'm a pediatrician based out at Stanger Hospital. And today I'd really like just to share Stanger's experience in linking community caregivers with children admitted with severe acute malnutrition. So community caregivers play an essential role in holistic health care. The re-engineering of the primary healthcare system has seen a structured approach in training and defining the roles of community caregivers. This includes linking them to patients with various conditions, including malnutrition, from different hospitals and clinics. However, the definition of linkage and the procedure to do so varies in different areas, and little formal feedback is received, leaving the question of success of linkage and the role it may play unanswered. So for those of you who don't know, this is Stanger Hospital. So this is KZN. Over here is a picture of Ilembe, which has four sub-districts which feed into Stanger Hospital. 2 sub-districts feed directly in, which includes 15 healthcare clinics, including 1 CHC. If we look at CCG coverage, Ilembe as a whole has 1 CCG per 200 households, and Kwadokuza is quite a bit further stretched, where each CCG is expected to cover almost 500 households. So why is malnutrition important, and why is it important to us at Stanger Hospital? So if we look, this is a DHIS data for the year 2015-2016. And if we look at the incidence of severe acute malnutrition, here in red, we see Ilembe is the highest in KZN with the incidence rate of about 7.5 per 1,000. At Stanger Hospital, about almost 25% of all patients admitted in 2015 had severe acute malnutrition. And this was the highest in the province. It was also the 4th highest across the country. Interestingly, this is data from CHIP specific to Stanger Hospital. If you look at the deaths and the case fertility rate, particularly here between 2014 and 2015, our case fertility rate, which had been static at about 14.9%, dropped to 8.2% between 2014 and 2015. Now, we think that's largely because we had a much stronger adherence to the WHO guidelines, and we are a lot more conservative in our management of patients with SAM than we had been in the past. But although we saw that dip in case fertility rate, if you look at our admissions between 2014 and 2015, they were relatively static. And that sort of really said it was time to step away from the hospital and to start fighting SAM at a community level. So we have a great tool to do that. As part of the KZN guidelines on the integrated management of malnutrition, every child that's admitted with SAM should be linked with a CCG, or community caregiver, for those who aren't familiar with the term. So on the 1st of January, Stanger adopted an SOP, a standard operating procedure, to address how we were going to link patients. And I'm going to give you a brief little synopsis of what that meant. So if a patient arrived and was admitted to the ward with severe acute malnutrition, the ward clerk would take the name, go to the fax machine, fax the name to the coordinator for CCGs and all the operational managers to the clinic, some of which didn't have fax machines. They would then inform the CCG of the patient. They would then go out, do a home visit, bring the report back to the clinic, it would get faxed back to the hospital, and all this was expected to happen within about 7 days. Now, the whole idea behind linkage is promotion of community education, prevention of SAM by household screening, prevention of severity on presentation by earlier detection, prevention of readmission, and to give us an improved insight into the home and socioeconomic circumstances of our SAM babies. So this is our 2015 linkage of patients of SAM with CCGs. Unfortunately, only 20% of our patients with severe acute malnutrition were linked with a CCG. And of those linked, only 60% of those we received reports for, and the quality and the timeliness of the reports was very suboptimal. So poor linkage was a major problem of our malnourished children. So we needed to identify gaps and implement improvement in our SOP and our practices to improve the linkage of all SAM patients with a community caregiver. So some of the gaps we identified, the definition of linkage was a big one. The quality of our statistics was erratic. The quality of the reports was poor. The process of linking was just taking too long. There were too many factors involved. Our timing of reports, we'd often receive reports after the patients were discharged, and this didn't allow us for good intervention. We had 2 sub-districts feeding into one hospital, and we didn't have equal control over the CCGs of both areas. There was poor accountability and follow-up for the patients who were not linked, and the critical stakeholders just weren't present at our monthly IMAM meetings, as they were still hospital-based. So when we went to tackle some of these, the first thing we had to do was get a proper definition of CCG linkage. And for our purposes, we thought that there were 2 requirements for successful linkage. The first being contact with the CCG, informing them of the patient, and the second being a report received back after a home visit. And ideally, this should be within the time frame of the admission. So we put our SMART action plan into place, and we started off with adjusting our SOP. The first thing we did was develop a direct means of communication between the hospital and CCGs, and this had a phenomenal impact. Instead of waiting for faxes and waiting for foot and word of mouth, our OM and our ward clerk picked up the phone with a list of CCGs, phoned them directly then and there. This improved time tremendously and had a knock-on effect with the quality of the reports we received. We improved our means of communication. Instead of relying on that one hospital fax machine that services everyone, and somebody goes to fetch their fax and throws your fax in a big heap, we found a fax machine with less traffic. We had great support staff from our lab, and our lab offered up their fax machine. And as a result, the minute a fax was received, someone from the lab brought it straight to us. And we also started a WhatsApp group. It was time to step up with technology and not rely on faxes. We decided to start small, so we started with our sub-district with the aim of extending the model once optimized. We improved adherence of our monthly SAM meetings by involving more stakeholders. Now we have a representative from every single quadriclusa clinic. The CCG supervisors are always there, and then there's either the OM or the nutritional advisor present, and this really tackled accountability. We improved the quality of the monthly meetings, where we now include training and increased awareness of severe acute malnutrition. And we took a bit of toll of our monthly statistics by verifying them. So when we reevaluate and then see, well, where are we in 2016, and this is up to the end of October, we now have 93% of our local patients linked. Of that 93%, 86% of these we've received reports for. Important to note that the minute we started the phone call immediately on admission, which was April, we've only had 1 patient not linked from our sub-district, and that was unfortunately in an area where there was no CCG. So what does this mean? So we have great linkage, but how is that affecting SAM? How is that affecting incidence and fatality rates in our hospital? So if we look at the admissions, if we compare 2015 to 2016, and this is running from January to October, there's a 40% decline in the number of admissions of patients with severe acute malnutrition. There's been a 65% decline in the number of deaths from severe acute malnutrition. And our case fatality rate has decreased from 8.1% to 4.9%. And the last 3 just show how great the gap between the number who could be linked and the number who are linked has improved. So what has driven this improvement? Well, there's a role directly played by the CCGs in linking. There's a slightly indirect role with a knock-on effect. And then we mustn't forget that I think stepping up our monthly IMAM meetings really played a contributing factor. So when we look at direct linkage with the CCGs, because we're getting the reports earlier from them, we're actually able to intervene appropriately. We no longer have the situation where houses are not found, because if the house isn't found, the CCG phones us immediately, we chat to the mom who's sitting right next to us, and we find that house. Because we're getting better reports, if there's issues that the mom's not forthcoming about, such as the neighbor and the granny report that the mom's actually absent quite a bit, we get that information and we can intervene while the mother's there. We have also had cases where the CCG's gone to do a home visit, she screened other siblings and brought the whole family into our hospital. Indirectly, we're seeing a drop in deaths and case fertility rate, and we think this may be due to earlier detection. They're picking up the SAMs earlier. Gone are the days where we are seeing the severe quashies that we saw from a few years ago. There's an increased awareness of malnutrition. The CCGs are giving phenomenal education during home visits, and they're screening siblings, which is leading to a decrease in our admissions. If we look at our monthly IMAM meetings, we're speaking more about SAM. We're increasing awareness and the magnitude of SAM in our population. And this has brought immense buy-in from all levels, not just with the hospitals, but with the CCG, with district stakeholders. It's really been phenomenal. And it's resulted in better accountability at both a PHC and a district level. We've been able to early identify and intervene in malnutrition and prevent the development of SAM by detecting more MAMs. And we've improved in-service training as part of our meeting to really empower the CCGs more when they do their home visits. But there is an obvious need for an objective measurement of the hard and beautiful work done by CCGs in relation to malnutrition. So in conclusion, through better definitions of linkage and a direct communication between CCGs and the hospital, Stanger Hospital has increased the rate of CCG linkage and improved the timeliness and quality of formal feedback of household visits. Improved CC linkage and extension of monthly SAM meetings to a sub-district level has resulted in a decrease in the admissions, deaths, and case fatality rates of severe acute malnutrition. And going forward, we aim to apply this model to other LMB sub-districts as well as other disease profiles. Thank you.
What a lovely result. Questions, comments, hands up, yes? Start with Janet, sorry, apologies.
Thanks for that very inspiring and wonderfully optimistic presentation. So I'm working in Khayelitsha and we're trying to set up a system of getting, what we call them CCWs, community, or CHWs. It's funny, all these different acronyms to visit. And I think my question is about, I've got lots of questions, but I'm going to confine them to two. The one is, do you use a referral form, or do you just say, here's the name of the child and this is the stated address on the thing? Because we've had this whole big thing about referral forms, and you've cut out the supervisors completely by the sound of things. It's directly from the hospital to the CCW. Then I've got, maybe answer that one first.
Okay, so what we've done is we've only optimized that first link. So now the hospital phones directly, straight to the CCG, no forms, no paperwork involved. And that means that the CCG sees that household within a day or two. Where the OMs become, where the CCG supervisors become involved in is that they collect the reports and send it back to us. We have also developed a standardized feedback tool. So what the CCGs have is a pile of things that they should look for specifically in a SAM household when they're assessing that household. And then they use that to report back to us.
Okay.
If that makes sense.
Yeah, that's up. And then just my last question was just, it's only for malnutrition. You're not using this for diarrhea or any other conditions?
At the moment, it's only malnutrition, yeah.
Question on that?
Hi, I'd just like to commend you. I have a history of working with Lorna in the Ugu district, and I know severe acute malnutrition is a huge problem in KZN. My question to you, I think you just briefly mentioned, but my question to you is the hospital management of SAM. You said that the CCG is contacted on admission once the child is diagnosed, and then is the child then discharged as an inpatient and then linked to the dietitian for follow-up as outpatient care, or was the child handed over to the CCG on discharge from hospital?
So I'm just trying to get the question right. So I think what you're asking, so upon discharge to hospital, so we have a whole separate down referral protocol. Every SAM is first, upon discharge, once they're ready for discharge, they'll always be seen first in our outpatients and by our dietitian. Once they're then happy, a message will go onto the WhatsApp group that they're ready for down referral, and the primary healthcare clinic will take over. The CCGs do, however, don't just do that first visit. They're phenomenal. They do follow-up visits the whole time. I see it in my clinic when I ask a mom, who's your Nompilo? She will tell me the name. She will tell me the phone number is in her phone, and she'll say she's visited me 4 times in the last 2 weeks.
One more question?
I want a clarification of process questions. The one is the role of the CCG. This is, you've got them around the country. What are your CCG on Nompilo specifically with it? So this is partly answered, but what are the skills they do? So there's this answer there. And the second question is the identifying and the picking up. What's happening in your district? So when they identify children with MAM or STEM, what are you able to offer? So those are what are you doing? What's the process? So to replicate this, what needs to
So our CCGs, but I mean, I think that's everywhere. They're just phenomenal people. We expect so much of them. With regards to malnutrition, over and above, when they do a normal household profiling or visit, they have their own separate screening tools that they go through. So for our purposes, if I have a patient that's admitted in the ward that are asked to do a home visit, the things in particular we're looking for is they screen the other children there. They do MUAC screening. They do have other programs where they dish out or where they hand out vitamin A supplements, food parcels, if it's part of a patient that's already in the program, and immunizations. The most important thing that we rely on them is screening of other children for SAM, and also the background of that home. So the socioeconomic circumstances. Often that's not forthcoming with a mom. So a mom may tell me something, she'll tell the social worker something else, but what's really happening in the household you don't know without a home visit. So we're relying largely on them for home visits. So I can give you some examples like I did earlier. We've had a few cases where the CCGs come back and said, guys, there's major problems here. This caregiver's not home a lot. She's often leaving that child with the oldest 7-year-old. I'm bringing the oldest 7-year-old to you as well. So it's things like that, which we have no idea. I mean, as hospital, as clinicians, we don't know what goes on in the community. It's a sad reality. We treat a disease, we send them packing. So it's really important because it gives us insight on what we're sending them to. And then that's helped us in that we can intervene, offer better social support to the mother, see where the root of the problem is.
Right. Thank you very much. Thumbs up. Lovely. Thank you.